Assalamu alaikum, our dear doctors. A new module of cardiology with new subject titled Dilated Cardiomyopathy or DCM, presented by Dr. Ahmed Shakir, Assistant Professor of Cardiology, and by me, Dr. Islam Shahata, Assistant Professor of Cardiology, Faculty of Medicine, Zagazig University. Our instructional objectives: to apply the prior learning of relevant biomedical and clinical sciences, describe the clinical presentations of dilated cardiomyopathy, outline the diagnosis workup of dilated cardiomyopathy, and explain the treatment plan and prognosis of dilated cardiomyopathy. Introduction: dilated cardiomyopathy or DCM is the most common type of cardiomyopathy, occurring mostly in adults between 20 to 60 years old. It affects the hearts, ventricles, and atria. Frequently, the disease starts in the left ventricle, often spread to the right ventricle, and then to the atria. Definition: DCM is a clinical diagnosis characterized by left ventricular or biventricular dilatation and impaired contraction that is not explained by abnormal loading conditions. Classification and causes: there are two categories: ischemic cardiomyopathy, which caused by coronary artery disease, and non-ischemic cardiomyopathy, which is due to primary genetic, which divided into acquired like myocarditis or peripartum cardiomyopathy or tachycardia induced cardiomyopathy, or mixed. Secondary causes, which include infections, for example viral like hepatitis C, COVID-19, Coxsackie B virus, Chagas disease, or collagen diseases like rheumatoid arthritis, systemic lupus erythematosus. Endocrinal causes like myxedema or diabetes or acromegaly. Toxic causes like alcoholic, chemotherapy, anabolic steroids. What about hemodynamics of dilated cardiomyopathy? As we see here in this figure, this is normal heart with normal left ventricular and right ventricular dimensions and left ventricular and right ventricular cavities, and this is dilated cardiomyopathy, which shows dilated left ventricle cavity and the thin wall of left ventricular cavity. First pathogenesis of hemodynamics: there is decreased systolic function, which leads to decreased contractility, so decreased ejection of blood and leads to finally to cardiac dilatation. Second hemodynamic process include adverse remodeling characteristics in DCM, which include functional mitral regurgitation, myocardial fibrosis, desynchronous ventricular contraction, and enlargement of other chambers. The last hemodynamic changes involve left ventricle or both ventricles. How to diagnose DCM? First of all, you ask about the history. The patient presented by history of shortness of breath or swelling of both legs and feet, fatigue, feeling overly tired, or inability to exercise or carry out activities as usual, or presented by weight gain, cough, and congestion related to fluid retention, or palpitation due to abnormal heart rhythm, dizziness or lightheadedness, fainting caused by irregular heart rhythm, or abnormal response of the blood vessels during exercise without apparent cause, or presented by thromboembolic events to the lung, which called pulmonary emboli, or to kidney, which called renal emboli, or brain, which called cerebral emboli or stroke, or limbs, which called peripheral emboli. And the classic symptoms of heart failure. What about clinical examination? General signs will present signs of systemic and pulmonary congestion, like any cause of congestive heart failure. And what about cardiac examination? You will see signs of biventricular enlargement, weak apex, weak heart sounds, S3 gallop, murmurs of functional mitral regurgitation and tricuspid regurgitation, and you asked to refer to clinical examination chapter for more details. What about the investigation of DCM? First, we will do chest X-ray, and we will see cardiac enlargement involving all the chambers and signs of pulmonary congestion in the X-ray as hilar congestion. Second, we will do ECG, and we will see in ECG low voltage or bundle branch block or depressed ST segment or flat or inverted T wave or arrhythmias like AF, ventricular premature contractions, or VTAC. Third, you will do echocardiography to the patient, and we will see dilated ventricles, atria with no hypertrophy, to differentiate between DCM and HOCM. Second, you will see also decreased contractility and impaired ejection fraction, and also you will see mitral regurgitation and tricuspid regurgitation. Fourth investigation, you can do exercise stress test, which increases heart rate in a controlled way to detect underlying ischemia and contractile reserve. Fifth investigation, you can do cardiac catheterization to detect coronary artery disease. The prognosis of DCM is poor, especially in patients with left ventricular ejection fraction less than 35%, or the patient who had right ventricular involvement, or the patient presented with NIHA functional class 3 or 4. The treatment of dilated cardiomyopathy included 5 items. First, low sodium diet. Second, non-competitive aerobic exercise. Third, drug therapy of congestive heart failure and arrhythmias if present. Fourth, implantable devices. Fifth is surgery. And we will discuss implantable devices and surgery later on in the following slides. Implantable devices divided into two options: either cardiac resynchronization therapy, which called CRT, or implantable cardioverter defibrillators, or ICD. First, we will discuss CRT, which will be done in some patients with advanced heart failure, which including biventricular pacing, which means a pacemaker that senses and initiates heartbeats in the right and left ventricle simultaneously to improve contraction of both ventricles and so improve survival and reduce symptoms and increases exercise capacity. And also for people with heart block or some bradycardias with slow heart rates, this pacemaker will also serve to maintain an adequate heart rate. But if the patient presented commonly with arrhythmias like VTAC or VF in DCM, so in those patients will prefer to implant ICD. So ICDs are suggested for people at risk for life-threatening ventricular arrhythmias or sudden cardiac death. The ICD constantly monitors the heart rhythm and delivers shocks to cause the heartbeat in a normal rhythm again. What about the surgical option for treatment of dilated cardiomyopathy? We have several options like surgical revascularization, as for example doing CABG to the patient, or left ventricular assist device, or cardiac transplantation. In conclusion, this algorithm summarizes the management of dilated cardiomyopathy presented to us with symptoms. We will start to give our patient treatment for heart failure. If hemodynamic improvement, so continue on medical treatment with careful follow-up. If no improvement of hemodynamics or progressive left ventricular dysfunction, so we will send our patient for endomyocardial biopsy. If revealed viral or bacterial infection, so we will give specific antiviral or antibacterial or immunomodulating therapy. If not revealed viral or infection or inflammation, so we will add additional treatment for heart failure, as we will discuss before, like implantable cardioverter devices or cardiac surgery, finalized by cardiac transplantation, which will end by cardiac or hemodynamic improvement. Thank you, our dear doctors, for your attention, and for any questions, please contact us and our official emails presented at this slides to you. Many thanks again, with my best wishes for you.